Good morning to one and all. Today's topic for seminar is functional anatomy of temporomandibular joint and its role in prosthodontics. We will be covering under following contents. Introduction. The masticatory system is extremely complex. It is made up of primarily of bones, muscles, ligaments, and teeth. The mechanics and physiology of this movement are basic to the study of masticatory function. Therefore, a sound understanding of joint type and its anatomy is essential to study the occlusion. Definition according to GPT-8, the articulation between temporal bone and the mandible, it is diathroidal, bilateral, clingymo-athroidal joint. According to GPT-9, the articulation between temporal bone and mandible, it is bilateral, diathroidal, bilateral clingymo joint. Bilateral because it is present on either side, left and right side. Diathroidal because it provides gliding movements on both sides. Clingymoid joint because hinging and rotating movement is provided in one plane. It is a freely movable joint. Synovial because it consists of synovial fluid, synovial cavity for lubrication. Compound joint, actually by definition, compound joint requires the presence of at least 3 bones, but TMJ is made up of 2 bones, that is temporal and mandible. Functionally, the articular disc serves as a non-ossified third bone, which is present between the temporal bone and mandible. Development of temporomandibular joint. There are 2 sets of articulation in development, the primary joint and the secondary joint. After 4 to 5 weeks of development, the stomatodium is surrounded by even number of mandibular processes from ventral part of first pharyngeal arch and even number of maxillary processes from dorsal part of first pharyngeal arch. In mandibular process, Meckel's cartilage is formed and the tympanic and mandibular process of Meckel's cartilage is completely developed in 16th weeks of prenatal life. Therefore, the primary joint persists up to 16 weeks of the prenatal life and it is derived from the first brachial arch. So this primary joint is the joint between the malleus and incus. Secondary joint. The thickened posterior ending of tympanic cartilage is the primordial cartilage called the malleus. Secondary joint exists beyond 16 weeks and this joint is articulation between the condyle and mandibular fossa. There are 3 main steps in TMJ development, the blastemic stage, cavitation and maturation stage. The blastemic stage starts from 7 to 8 week, cavitation is from 9 to 11 week and after 12th week is the maturation stage. The development of condyles, articular fossa and articular disc capsule is formed in the blastemic stage. Beginning of lower joint space, development and condylar chondrogenesis occurs in the cavitation stage. 10 to 11 weeks, ossification of temporal component occurs. After 12th week, condylar cartilage becomes conspicuous and mesenchyme condenses to form the articular disc. Joint cavities are formed in the 13th week and 14th week, both the joint cavities are evident. Condylar cartilage, the endochondral ossification, except the head of condyle, remains as the cartilage in the 20th week. 22nd week, fossa can be easily distinguished. Articular eminence becomes evident. 19th to 20th week, the disc takes on its fibrocartilage tissue composition. 26th week, definite cellular morphology of capsule and synovial lining formed by the endothelial cells is produced. So this is the summary of embryological development, the primary temporomandibular joint, and this is the secondary temporomandibular joint. Bony components of TMJ, condylar head of the mandible and articulating surfaces of temporal bone are the bony components, and soft tissue components are the articular disc, ligaments, and muscles of mastication. Condylar head of the mandible. The total mesiolateral length of the condyle is between 18 to 23 mm and the anterior-posterior width is 8 to 10 mm. Because of different angles and asymmetry of condyles, the medial pole is the only logical common rotation point that would permit a true hinge axis to occur on the fixed axis. A and B, A is the posterior view and B is the anterior view. The dotted line represents the articular surface. The condyles seem to slightly rotate so that if an imaginary line is drawn through the lateral and the medial poles, it would extend medially and forward towards the anterior border of the foramen magnum. This represents the inferior view of the surface of the cranium and mandible. Articulating surface of the temporal bone. Articulating part of mandibular condyle articulates with the squamous part of temporal bone called the glenoid, articular, or the mandibular fossa. This here is the mandibular or the glenoid fossa. Posterior to the fossa is the squamotympanic fissure, which extends mediolaterally. Anterior to the fossa, convex bony prominence is present, which is the articular eminence. Articular eminence. Immediately anterior to the fossa is the convex bony prominence called articular eminence. The degree of convexity of articular eminence is highly variable, but it is very important since the steepness of this surface dictates the pathway of condyle when the mandible is positioned anteriorly. The posterior roof of fossa is quite thin, indicating that this area is not involved for heavy forces. But the articular eminence, however, consists of thick, dense bone, and it is more likely to tolerate such stresses. According to the study conducted by Joan et al., named flattening of articular surfaces is associated with loss of occlusal support. Here, it was a retrospective radiological study in which he examined 1,700 OPGs, measured the inclination of posterior slope of articular eminence, and concluded that there is a great clinical correlation between the occlusion and dentition. Therefore, if there is no occlusion in the posterior contact, there will be flattening of articular eminence. Articular disc. It is composed of dense fibrous tissue. TMJ is a load-bearing joint. All the articulating surfaces of the condyle, the fossa, and the eminence are covered with avascular tissue. Devoid of blood vessels is a proof that these structures are responsible for heavy stresses, and therefore TMJ is a load-bearing joint. The disc divides the joint into two components, the upper component and the lower component. The upper component is present between the squamous part of temporal bone and superior concave surface of articular disc. And therefore, this joint is known as the squamomeniscus joint, and it is responsible for rotation and translatory movements. The lower joint is present between the concave inferior surface of articular disc and head of the mandibular condyle, which is convex. Therefore, the articular disc is biconcave in nature, and the lower joint is responsible for pure rotational movement. In the lateral view, the disc is divided into three regions: the anterior region, the middle region, and the posterior region. Central and the intermediate zone is the thinnest, and normally this is the articular surface of the condyle is located in the center or the intermediate zone of the disc. From anterior view, the disc is generally thicker medially than laterally. Therefore, the working area of TMJ is the superior anterior part of condyle, which articulates with the distal incline of lower half of the articular eminence of the temporal bone, not the fossa. Posteriorly, the disc is attached to loose connective tissue that is highly vascular and innervated. It is known as the retrodiscal tissue or the posterior attachment. Superiorly, this is bordered by lamina of connective tissue, which contains the elastic fibers. It is known as the superior retrodiscal lamina, which is present here. And inferiorly, it is bordered by the inferior retrodiscal lamina, composed chiefly of collagenous fibers, but not elastic fibers. Anteriorly, the disc is attached to the capsular ligament by tendons fibrous to superior lateral pterygoid muscle. The internal surface of the cavities are surrounded by specialized endothelial cells, which produces the synovial fluid, which fills both the joint cavities. Thus, the TMJ is referred as the synovial joint. Synovial fluid serves two main purposes. It provides the medium for metabolic requirements of the tissue and lubrication. Types of joint lubrication. There are two basic types of joint lubrication: boundary lubrication and weeping lubrication. Boundary lubrication occurs when the joint is moved and the synovial fluid is forced from one area to the other cavity. This boundary lubrication prevents friction in the moving joint, and it is the primary mechanism of joint lubrication. Weeping lubrication refers to the ability of articular surface to absorb a small amount of synovial fluid. This is the mechanism by which metabolic exchange occurs, but it does not happen in moving joint, only it helps to eliminate the friction in the compressed area. Histology of the articulating surfaces. There are 4 distinct layers. The articular zone, made up of fibrous connective tissue. This is less susceptible to aging, better ability to repair itself. Proliferative zone, proliferation of articular cartilage in response to functional demands, and undifferentiated mesenchymal tissue is found. Fibrocartilage zone, collagen fibers are arranged in bundles in cross pattern. It offers resistance against compressive and lateral forces. Calcified cartilage zone, site for bone remodeling activity, chondrocyte and chondroblasts are present. The fibers are tightly packed and are able to withstand the forces of movement. The reason for using the fibrous cartilage and not the hyaline cartilage in TMJ are fibrous cartilage is more susceptible than the hyaline cartilage to and better for the effects of aging. It is less likely to break down over time, and it has better ability to repair over hyaline cartilage. Ligaments of TMJ, they play an important role in protecting the structure, made up of collagenous connective tissue fibers that have particular lengths. Ligaments do not enter actively into the joint function, but instead they act as passive restraining devices to limit and restrict the border movements. There are 2 types of ligaments, functional ligaments and accessory ligaments. The functional ligaments are divided into collateral ligaments, capsular ligaments, and the temporomandibular ligament. Accessory ligaments are the spinomandibular ligament and the stylomandibular ligament. The collateral ligaments, they are also known as the discal ligaments, and they are 2 in number. The medial discal ligament is attached to the medial edge of the disc and the medial pole of the condyle. And the lateral discal ligament is attached to the lateral edge of the disc and to the lateral pole of the condyle. The functions of the discal ligaments is to restrict the movement of the disc away from the condyle. The discal ligaments are true ligaments composed of collagenous connective tissue fibers. Therefore, they do not stretch. These ligaments are responsible for dividing the joint mediolaterally in superior and inferior joint cavities. Clinical importance is strain on these ligaments produces pain because discal ligaments have a vascular supply and they are innervated. Capsular ligament, entire TMJ is surrounded by the capsular ligament. Superiorly, the fibers of capsular ligament are attached to the temporal bone along the border of articular surface and articular eminence. Inferiorly, the fibers of capsular ligaments are attached to the neck of the condyle. The function of the capsular ligament is to encompass the entire joint, thus retaining the synovial fluid. It also provides the proprioceptive feedback regarding position and movement of joint. Temporomandibular joint ligament, it is also known as the lateral ligament. It is present on the lateral aspect of the capsular ligament, reinforced by strong tight forces. It composed of 2 parts, outer oblique portion and inner horizontal portion. The outer oblique portion limits the extent of mouth opening, and the inner horizontal portion limits the posterior movement of condyle and the disc. The effectiveness of temporomandibular ligament is demonstrated during the cases of extreme trauma to mandible. In such cases, the neck of the condyle will be fractured first before the retrodiscal tissue because the retrodiscal tissues are protected by the temporomandibular ligament. Spinomandibular ligament, it is an accessory ligament. It arises from spine of sphenoid bone and extends downwards to small bony prominence known as lingula, which is present on the medial surface of mandible. It does not have any significant limiting effects on the mandibular movement. Stylomandibular ligament, it is also an accessory ligament. It arises from the styloid process and extends downwards and forward to the angle of the mandible. It becomes stretched when the mandible is protruded and relaxed when the mandible is open. Nerve supply to TMJ. The nerve supply to TMJ is basically from the auricular temporal nerve. It is sensory innervation. The specific mechanics of the proprioceptive receptors are 4. The Ruffini endings function as the static mechanoreceptors which position the mandible. The Pacinian corpuscles are the dynamic mechanoreceptors which accelerate the movement during reflexes. The Golgi tendon organ functions as the static mechanoreceptors, and it also protects the ligaments. And the free nerve endings are the pain receptors which are present abundantly. They are for protection of TMJ itself. Blood supply of TMJ. Dominant vessels are the superficial temporal artery from posteriorly, the middle meningeal artery, inferiorly the internal maxillary artery, and deep auricular, tympanic, and ascending pharyngeal artery also provide blood supply to the joint. Muscles of mastication. There are 4 muscles of mastication, namely temporalis, masseter, lateral pterygoid, and the medial pterygoid. Masseter means, a Greek word means chewer. We will be seeing the following slides in the upcoming video. Masseter, it is the thick rectangular muscle of mastication, here highlighted in the green. It consists of a superficial part, middle part, and the deep part. The superficial part arises from the zygomatic process and anterior 2/3 of zygomatic arch, and the deep part arises from the deep surface of the zygomatic arch. Insertion of the superficial part is in the maxillary tuberosity, masseteric tuberosity, and the deep part is outer surface of the mandibular ramus. This is the masseteric tuberosity highlighted in the green where the insertion happens. Deep parotid gland lies deep on the anterior side of the masseter and it's duct coursing underneath the zygomatic arch across this muscle. This is the masseter muscle and this is the parotid gland. The blood supply is by masseteric artery, branch of the maxillary artery, and the nerve supply is by the masseteric nerve, a branch of mandibular nerve. Functions of the masseter. It is a strong elevator of mandible, moves the mandible forward, and stabilizes the tension of articular capsule of the temporomandibular joint. Palpation of the masseter muscle. The patient is asked to clench their teeth. Using both hands, the practitioner should palpate the muscle on both the sides extraorally, making sure that the patient is continuously clenching during this procedure, because clenching activates the masseter muscle. Palpation should start from the origin of masseter muscle bilaterally along the zygomatic arch and continue to palpate down the body of mandible where the masseter is attached. Temporalis muscle. The temporalis muscle is a flat fan-shaped muscle on the lateral side of the skull, highlighted here in green. The origin of the temporalis muscle is from the temporal fossa and lateral surface of the skull. The insertion of the temporalis muscle, it extends downwards and forms a tendon that inserts onto the coronoid process and anterior border of the ascending ramus. Nerve supply, it is supplied by the deep temporal branches of the anterior trunk of the mandibular nerve. And blood supply is the deep temporal part of the maxillary artery. The functions of the temporalis muscle. Anterior part moves the mandible forward, also known as protrusion, and the posterior part, which runs horizontally, pulls the mandible, also known as retrusion. The activation of the entire muscle moves the mandible dorsocranially, leading to strong jaw closure or elevation. Palpation. Muscle is divided into 3 functional areas and therefore each area is independently palpated. Ask the patient to clench the teeth and locate the muscle. Anterior portion is palpated above the zygomatic arch. The middle portion is palpated above the TMJ and superior to the zygomatic arch, and posterior region is palpated above and behind the ear. Medial pterygoid. Medial pterygoid is also called the internal pterygoid muscle. It is quadrilateral in shape, highlighted here in green. Head and a large deep head. The superficial head originates from the tuberosity of maxilla. The deep head originates from the medial surface of lateral pterygoid plate. Insertion of pterygoid tuberosity, which is present on the inner surface of mandibular angle. Now, along with masseter, this muscle forms a sling around the mandible, which helps in the movement of the jaw. It is palpated medially to the ramus of mandible, both intra and extraorally, but intraoral palpation is difficult as the attachments are present within the skull. It is supplied by the medial pterygoid nerve from the main branch of the mandibular nerve, and blood supply is by medial pterygoid from the maxillary artery. Contraction of medial pterygoid muscle elevates the mandible and causes the jaw closure, jaw protrusion. These movements are also reinforced by the muscles formed by the masseter. Palpation is by placing the finger on the lateral aspect of the pharyngeal wall of the throat. Palpation is difficult and very uncomfortable to the patient, and therefore functional manipulation is done. What is functional manipulation? Basically, each muscle is contracted and then stretched. If the muscle is true source of pain, both contraction and stretching will increase the pain. Medial pterygoid is elevator. Therefore, when contraction or when the teeth come together in clenching, the pain will increase if medial pterygoid is the source of pain. And medial pterygoid also stretches when the mouth is open wide. Same way, if it is the source of pain, opening the mouth wide will increase the pain. Lateral pterygoid. The pterygoid muscles are also known as the wing muscles. It involves the medial pterygoid and the lateral pterygoid. This is the, in green is the lateral pterygoid and in pink is the medial pterygoid. The lateral pterygoid is also known as the external pterygoid. This muscle has two heads which lie almost horizontally to each other. It has the small superior head which arises from the infratemporal fossa of greater wing of sphenoid, and the large inferior head which arises from the lateral surface of lateral pterygoid plate. The insertion of the small superior head is inserted in articular capsule and disc 30 to 40% of the times, and neck of the condyle 60 to 70% of the times. Insertion of the large inferior head is neck of the condyle. The innervation is lateral pterygoid nerve, and it is the branch of mandibular nerve. The function, only muscle of mastication which opens or depresses the jaw. The inferior lateral pterygoid causes protrusion of the jaw, and the superior lateral pterygoid is active mainly during the power stroke. Power stroke is basically when movements are against the resistance, like clenching. Bilateral activation of the jaw causes protrusion. And unilateral activation of the jaw causes lateral protrusion. Palpation. Place the forefinger or the little finger over the buccal area of maxillary molar region and exerting pressure in posterior, superior, and medial direction behind the maxillary tuberosity. This palpation is extremely uncomfortable and almost impossible because the attachments are to the sphenoid. Therefore, functional manipulation is done same like the medial pterygoid. Functional manipulation of the muscle of the superior lateral pterygoid muscle. On contraction, clenching of the teeth increases pain. That means the muscle is the source of pain. And on stretching, clenching on teeth increases pain, and clenching on separating and opening mouth, there is no pain. This is how we differentiate from the medial pterygoid muscle. Digastric muscle, though it is not included in the muscle of mastication, it is an important depressor of mandible. It is divided into two bellies. Posterior belly originates from the mastoid notch, just medial to mastoid process, and anterior belly originates from the fossa on the lingual surface of the mandible. Both bellies are inserted at the same intermediate tendon, which is attached to the hyoid bone. The function is to depress the mandible. Nerve supply of anterior digastric is the mandibular branch of trigeminal nerve, which is the mylohyoid nerve, and posterior digastric branch of the facial nerve. Blood supply is by the submental artery for the anterior digastric and posterior auricular and occipital artery for the posterior digastric. Let's come to the biomechanics of TMJ. It is a complex system because two temporomandibular joints are connected to the same bone. Each joint cannot perform the function without influencing the other joint. Its structure and function can be divided into two distinct systems, one joint system and two joint system. One joint system, here the tissue that surrounds condyle and articular disc. Here the disc is tightly bound to the condyle by lateral and medial discal ligaments. Therefore, the only movement that can occur between the surfaces is the rotation of disc on the articular surface of condyle. It is also known as the inferior compartment of the joint. Second joint system, here the condyle disc complex is functioning against the mandibular fossa. Since the disc is not tightly attached to the articulating fossa, translatory movement is possible between the surfaces of the superior cavity. Now, width of the articulating space varies with intra-articulating pressure. When the pressure is low, such as in closed position or rest position, the disc space widens. When the pressure is high in movement, the disc space narrows. For the stability of joint, the disc should permit constant contact with the articulating surfaces of the joint. So when the pressure is low, a thicker portion of the disc is rotated to fill the space. And when the pressure is high, condyle seats itself against the thinner intermediate zone. So technically, the disc could be rotated anteriorly or posteriorly for the stability of joint. Direction of the disc rotation is determined by the structure attached to the anterior and posterior border of the disc. So the structure which is attached on the posterior border of the disc is the retrodiscal tissue, and therefore it is known as the posterior attachment. During mandibular opening, the condyle is pulled forward during the articular eminence, which leads to the stretching of retrodiscal lamina and creates a force to retract the disc. So the muscle pressure and the morphology of disc prevents the over-retraction. The retractive force of retrodiscal lamina is only present during wide opening movement. Superior retrodiscal lamina is the only structure capable of retracting the disc posteriorly on the condyle. Attachment on the anterior border of the disc is the superior lateral pterygoid muscle. Now, when this muscle is active, fibers of the muscle pulls the disc anteriorly and medially. But when the inferior lateral pterygoid is protracting the mandible forward, the superior lateral pterygoid is inactive and therefore does not bring the disc forward with the condyle. The disc relationship is maintained during minor passive rotational and translatory movement of the mandible. As soon as the condyle is moved forward, retractive force of the superior retrodiscal lamina is greater than the muscle force, so the disc is rotated posteriorly. When the condyle is returning to the resting closed joint position, the tonus or the contraction of the muscle becomes predominant and the disc is positioned forward as far as the disc space permits. Power stroke. Power stroke refers to the movements that involve closure of mandibles, such as chewing or clenching the teeth together. To prevent, when one bites down on a hard food, it leads to increase in the interarticular pressure on the contralateral side and sudden decrease in the intraarticular pressure on the same side. This leads to dislocation of the joint on the same side of mandible. To prevent dislocation, superior lateral pterygoid comes in action during the power stroke by rotating the disc forward on the condyle so that the thicker posterior border of disc maintains the occlusal contact. And this is how the stability is maintained during power stroke. Peculiarity of TMJ, it is bilateral dry arthrosis, that is right and left functions together. Articulating surfaces are covered with fibrocartilage and not hyaline cartilage. Only joint in human body having rigid enough point of closure of teeth making occlusion contact. In contrast to all other joints, TMJ is last to start to develop, that is in the 7th week of intrauterine life, and it develops from different blastema. The reason for using collagen fibers instead of hyaline cartilage in TMJ is that stiffer cartilage that works well in other joints would not be enough to change the shape as it conforms to the contours of the convex eminence in sliding movements. These are the TMJ disorders. The condylar disc disorders are the disc displacement with reduction, disc displacement with intermittent locking, disc displacement without reduction. Structural incompatibility of articulating surfaces are deviation, adhesion, subluxation, and luxation. Inflammatory disorders are synovitis and osteoarthritis, also known as the degenerative diseases. Inflammatory disorder of associated structures are temporal tendonitis, stylomandibular ligament inflammation. Palpation of TMJ. Lateral aspect of the joint is palpated with mouth closed. Lateral aspect of the joint is palpated with opening and closing movements. With the patient's mouth fully open, the clinician moves the finger behind the condyle to palpate the posterior aspect of the joint. Radiographic examinations of TMJ. Now there are conventional imaging, that is the transcranial projection, which depicts the lateral aspect of glenoid fossa, articular eminence, joint space. Here the rays are 25 degrees parallel to the plane. Transpharyngeal view. Transpharyngeal is also known as, here the central ray is directed 5 to 10 degrees. This is the condyle, head of the condyle, and this here is the articular eminence. Next comes the conventional OPGs. These OPGs are good enough for the clinical examiner to exclude the major pathologies, but proper disc condyle assembly is not seen as there is lot of overlapping. Arthrography, single contrast arthrography, injection of contrast medium, and there is also double contrast arthrography, but it is a very invasive procedure for TMJ examination. Then comes the computed tomography. A represents the lateral image slice and B here is the middle slice of the same joint. Computed tomography is one of the best methods right now for TMJ examination because it provides imaging in axial, coronal, sagittal and open mouth movements. This is the ultrasonic scan of the TMJ indicating disc, condyle, temporal bone and joint components. Thermography syndromes can be assessed to show the combined effects of inflammation as well as neurological dysfunction. MRI is the best image for soft tissue and for TMJ involving effusion disorders and degenerative disorders. Chairside investigations, joint vibrational analysis. This measures the joint vibrations through electrovibratorography and it is more reliable than physical examination alone and can serve as a non-invasive method along with other procedures. Here basically the system is directly connected to an internal circuit using a compatible computer which has the BioJVA software. The device is placed over the patient's head over the TMJ area and the amplifier is hung in the patient's neck. This representation is the normal vibration of the joint. Electromyography measures the muscle response to electrical activity in response to nerve stimulation of the muscle. Here the thin surface electrodes like pure silver is placed for the muscle to be checked. And the reference electrode is placed on the patient's sternum. And then the patient is asked to perform the muscular movements. Occlusal T-scan, it is the diagnostic device that measures the relative biting forces, dynamics, occlusal force, and location and timing. According to the studies concluded, only 20% of the time, similar loads resulted in similar marked area when you correlate with the articulating paper. T-scan puts the articulating paper mark directly into the software by showing the force of the marks of the patient. It also helps in clarifying patient's occlusion by reducing the chair side time. It displays the force in 2D view and 3D view. This here is the 2D view which resembles the articulating paper what we use. It depicts the left and right side. This here is the 3D view. The advantage of 3D view is that patient motivation can be easily done. Higher the column, higher the force exerted. It also has a force legend which depicts colors. Blue color indicates low forces, green and yellow indicates the medium forces, and high indicates the red and pink. The main advantage over the articulating paper is that we understand exactly when which tooth is contacting first and which occlusal interference occurs first. There is center force of trajectory line, and there is this represents the force balance of the time and the bite. This line is similar to the path of closure. The red and white marker depicts the center of force. And T-scan also provides the customizable arch. The settings are saved for the patient each time to record a new move. 6 ways to verify that the TMJ are healthy. Screening history. Every patient should be asked key questions about the TMJ before treating any disorder. Questions like, for muscles, do you have frequent headaches? If so, where and how often? And do you have any soreness in any muscle? Joints, have you been injured? Do you experience any joint noises like pops or clicks? Examined by Doppler analysis. Have you noticed any changes in the bite? And aesthetics. Load test for verification of comfort in centric relation or adaptive centric posture. Any side of tension or tenderness warrants further evaluation. For healthy joint, the load test should be negative. Range and path of movement test. Normal range is 10 to 14 in protrusive, about 10 mm towards the right and left, and maximum opening without discomfort is 40 to 60 mm. Doppler analysis. An intact healthy joint is quiet on rotation and translation without any crepitation and noises. Radiographic imaging is not necessary if other tests and history is negative. Next is the anterior bite plane for muscle deprogramming, can be used to determine if the occlusion is the factor or not. If biting on the anterior bite plane eliminates the pain, that means occlusion is the problem. And if the biting on the bite plane, still the pain continues, you have to suspect the intracapsular disorder. 8 changes in TMJ. Condyle becomes more flattened, fibrous capsule becomes thicker, and there is osteoporosis of the underlying bone. Thinning or absence of the cartilaginous zone. In articular disc, the articular disc becomes thicker. It shows hyalinization and chondroid changes. The synovial fluid becomes more and more fibrotic with thick basement membrane, and the walls of the blood vessels are thickened. Prosthodontic implication of TMJ, the teeth must fit into harmony of jaw relationship, not vice versa. Changes occur slowly in mandible and maxilla over a period of time. Articular surface of TMJ undergoes slow but continuous remodeling throughout life. Centric relation. An understanding of centric relation is an integral part of clinician decision making in several restorative procedures. Of all jaw relations, a dentist must record centric relation, which is the only clinically comfortable, repeatable, and logically jaw position, and most important and critical. How the mandible goes into centric relation. Triad of strong elevator muscles moves the condyle disc assembly up onto the posterior slopes of the articular tubercle. Later, the lateral pterygoid muscle relaxes and stays relaxed during the complete closure. Complete seating of the condyle in the superior most position. GPT-3 defines centric relation as the most retruded physiological relation of the mandible to the maxilla and forms which individual can make the lateral movements. Dawson defines centric relation as the most superior position of the condyle, which can assume in the glenoid fossa, and it is not unstraight. It is not most retruded position because when you force the condyles distal to the centric relation, and distal displacement can occur. It is not unstrained because it is achieved by firm contraction of the elevator muscle. Centric relation is maxillomandibular relationship independent of tooth contact because it is also present in edentulous patients in which the condyles articulates in the anterior superior position against the posterior slopes of the articular eminence. In this position, the mandible is restricted to a purely rotatory movement. From this, the unstrained physiological maxillary mandibular relationship, the patient can make vertical, lateral, or protrusive movements, and this position is clinically useful, repeatable, and reference position. As stated by Dawson, mandible is in centric relation if the 5 criteria are fulfilled. Disc is properly aligned on both condyles. Condyle disc assemblies are at highest point on the posterior slope of the articular eminence. Medial pole of the condyle disc is braced by the bone. Inferior lateral pterygoid has released its contraction and is completely passive. TMJ can accept firm compression loading with no sign of tenderness. Adaptive centric posture. Now, it is manageable, stable relationship of mandible to maxilla that is achieved when the deformed TMJ have adapted to a degree that can comfortably accept firm loading when completely seated to the most superior position against the eminence. 5 criteria for adaptive centric posture. The condyle comfortably seated at the highest point against the posterior eminence. The medial pole is braced by the bone. The inferior lateral pterygoid is completely passive, and the condyle to fossa relationship is manageably stable. Load testing produces no sign of tension or tenderness in either TMJ. Let's see the bilateral manipulation of Dawson. It is most consistent, repeatable, and most easily learned. It provides the method of verification of correctness of the condylar position, alignment of the condylar disc assembly, and integrity of the articular surfaces. Step 1, recline the patient all the way back and point the chin up. Now the chin is pointed upward so that there is no protrusive movement. Step 2, stabilize the head. Step 3, after the head is stabilized, lift the patient's cheek again to slightly stretch the neck. Step 4, gently position the 4 fingers of each hand on the lower border of mandible. The little finger should be slightly behind the angle of mandible. This is the path of your fingers. Keep all the fingers tightly together during the procedure. Step 5, bring the thumbs together to form a C with each hand as shown in the picture. The thumbs should fit the notch above the symphysis. No pressure should be applied at this time. All movements should be made gently. Step 6, with a very gentle touch, manipulate the jaw so that it slowly hinges open and closed. As it hinges, the mandible will usually slip up into the centric relation automatically if no pressure is applied. No jiggling is done, and this particular procedure is known as romancing the mandible. Step 7, verify the centric relation position. Upward finger pressure and the downward thumb pressure is important. When it is possible to freely and painlessly arc the mandible, the dentist is ready to close the mandible to the first point of contact. Methods for recording centric relation as given by Hartwell, the functional methods which include the needle and Patterson method, graphic method, intraoral devices and extraoral devices, and physiological method. Evaluation of graphic arch tracing, Gothic arch tracing. Geissy divided into 6 patterns. It is also known as the needle point tracing or the Gothic arch because it looks like the Gothic arch architecture. Now the classical pointed form is seen in well-defined apex. The sharp apex indicates the centric relation. This occurs when there is symmetry between the left and right lateral components of the joint. The angle is 120 degrees. Classical flat form, it is similar to the typical form, but the angle is more than 120 degrees. It is seen when there is marked lateral movement of condyle in fossa. Now, apex absent or round form, it shows in weak retrusive movement. Here, the patient needs to be trained. Asymmetrical form, left and right meet in an arrow, but their inclination to protrusive path is not symmetrical. Miniature Gothic arch tracing, it is due to the restrictive mandibular movement and improper seat of denture bases. And also it is seen in long period of edentulousness. Now vertical line protrudes beyond the arrow tracing. It is seen when protrusive path extends beyond the apex. Always in Gothic arch tracing, there should be a sharp apex, not the blunt apex. If there is blunt apex, we have to repeat the procedure. Management of edentulous patients with temporomandibular disorders by using CAD/CAM processes. Here, initial examination shows poor aesthetics with existing complete dentures. There is the frontal view, lateral view, intraoral view, and these are the existing dentures. The 77-year-old man with 15 years of previous history of wearing dentures reported with a chief complaint of difficulty in mastication, denture instability, and altered facial appearance. On examination, habitual non-functional palpation was noted. Tenderness of palpation to the lateral pterygoid was also present, including crepitus sounds were heard. And guiding the jaw in the centric relation was also difficult. Here, definitive impressions of maxillomandibular relation registered by using the central bearing device attached to the custom tray. This is the intraoral tracer shown in the picture. A lateral view of digitalized impressions and occlusal plane included in the denture design, arrangement of artificial teeth according to the occlusion rims, and here C depicts the evaluation of milled acrylic resin trial dentures. Digital occlusal contacts for virtual tooth arrangement, and B is the CAD/CAM dentures with occlusal contacts marked. Gothic arch tracings. Now, Gothic arch tracings were recorded before placement of the CAD/CAM dentures and recorded 45 days after placing of the CAD/CAM dentures. You can see that in the first Gothic arch tracing, the apex and the entire tracing is asymmetric, and after the stabilization of the joint and CAD/CAM dentures, there is a proper arrow which indicates stable condyle relationship. Subluxation of temporomandibular joint, a clinical review. This article I have taken to show the axiographic representation. There are several electronic recording systems like axiographies for registration of the mandibular movements based on the ultrasonic measuring device. In addition to the amount of movement, the quantitative characteristic of the movement, along with symmetry analysis of the performance for left and right condyles, is shown. Here, this arrow indicates that there is dislocation of the joint. Developmental anomalies of TMJ, aplasia of mandibular condyle, there is congenital or hereditary absence of the condyle. Hypoplasia of the mandibular, there is reduced formation of the mandibular condyle. Hyperplasia of the condyle, there is overgrowth of the condyle as shown in the OPC. Alkylosis is the bony fusion between the articular surfaces. This is a bifid condyle. Alkylosis is a temporomandibular joint, impression-free CAD/CAM based joint replacement using specific implants. Alkylosis of the temporomandibular joint involves the bony fusion of the mandibular condyle to the skull base. Trauma-induced alkylosis is considered most frequent type, and that develops from fibrous organization of hematosis. Skeletal class 2 with 7 mm distal bite, maxillary hypoplasia, and strongly restricted mouth opening was seen. TMJ imaging was carried out using cone beam computed tomography on the day of first presentation. Here, with the interdisciplinary approach, the surgical prosthetic treatment was bilateral alloplastic TMJ replacement was used. The prostheses were fabricated solely based on the 3D printed models. Patient intraoral impression was not possible due to the restricted mouth opening. This is the intraoral situation with presentation of fixed interposition osteoplasty after T41 osteotomy. There is excision of the alkylotic mass. Patient-specific customizable TMJ implant is placed on the right side. And this is the clinical situation 6 months after the surgery with increased mouth opening. Intraocclusal appliances therapy like occlusion splints, night guards, or bruxism appliances have reported a clinical success for TMJ disorders. Although there are a large variety of appliances, 2 major types of stabilization appliances are used. The stabilization appliances are designed to provide stabilization of the joint. An anterior positioning appliance, also termed as the mandibular orthopedic repositioning appliances. Occlusion appliances are divided by dorsal into permissive splints or the muscle deprogrammers, for the non-permissive splints and the pseudo-permissive splints. This here is the Michigan appliance, which is a stabilization appliance. It is put on the maxillary arch cover. It's like a full coverage splint. This is the anterior repositioning appliance, posterior bite plane, anterior bite plane, soft or residual appliance, hydrostatic appliance or equalizer. Here water is used as a medium for lubrication. Types of occlusal splints in management of temporomandibular disorder. They include reassurance, that is the patient education, self-care and behavior therapy, physiotherapy, occlusal splint therapy, drug therapy, and occlusal adjustment. The mechanism of action of occlusal appliances and occlusal disc engagement, restoring the vertical dimension of occlusion, joint unloading or TMJ repositioning. Commonly, there are two different materials based on the consistency: hard acrylic resin occlusion appliances or soft or resilient occlusion appliances. There are also dual laminated present. A graphic evaluation of intermaxillary relationship before and after therapy with Michigan splint. Now, the effect of Michigan splint was evaluated graphically into a group of 19 patients. Gothic arch tracings were registered before and after period of 4 months. A lateral displacement of apex of Gothic arch occurred in all patients. This here tendency towards regularity in the shape of the tracings in the second registration in all patients after use of Michigan splints for 4 months. This finding can be correlated with increased harmony in the mandibular dynamics. Conclusion: dentists must assess the oral function of the patient prior to any treatment, since mastication is the most important oral function and it is closely associated with the TMJ. Examination of the TMJ and thorough knowledge of its anatomy and functioning are the keys to successful prosthodontic treatment. These are my references. Thank you.